Hello, everyone. It is 2:11 p.m. on March the 11th, 2024. I apologize for starting late. If some of you came online and then couldn't get signed into the class, again, I apologize. I've probably been working on this process for 20 to 30 minutes now, trying to get signed on. I'm not sure what's going on, whether it's internet connection or what. But we're going to just go ahead and get started. If you missed the class, or if you tried to sign in, couldn't, and just gave up and left, or if regardless, I'm going to post this recording tonight for everybody. I'm also going to go ahead and email everyone a copy of the PowerPoint that we're going to use for this evening's lecture. If I can't move, oh yeah, I'm still learning to do this. I was able to move my screen right and look at myself. Okay. Let's see if I can't share my screen with everybody. Well, let's see what's going on. Hopefully I'm sharing my screen with everybody now. Let's see. Stop sharing. I don't know if my computer's doing weird things or if I'm doing weird things. But we're going to find out. It's almost like the program has, or computer's completely forgotten the program. Now we are configuring. But don't worry, folks, if you see a email come through for you this evening, I'll go ahead and put the start time on it for you so that we don't have to guess. Okay, well, I'm just going to go ahead and get started when I get back to the beginning of my PowerPoint. And see what I can do. Let's see. Okay, what I'm going to do is tell everyone to start the recording or start watching the recording at 12 minutes and 45 seconds so that we can all start at the same point. If you can't see the slideshow on your end, just go ahead and download the Respiratory Emergencies PowerPoint that I'm going to send you this evening, and maybe you can kind of follow along with it. There's two videos in the slideshow that go over respiratory anatomy and physiology. Those are some good videos if you want to go ahead and watch those. The links are in the slideshow, and we'll see them again on Thursday when we meet at the breaks. Okay, we're going to talk about the process of breathing. And to start with, we're going to talk about the term inspiration, which means to breathe in. That's an active process where the intercostal muscles, if we all remember the intercostal muscles of our chest that are in between our rib cage, and also the diaphragm will contract. And when that happens, the size of the chest cavity expands and air flows into the lungs. This is also called inhalation. In layman's terms, this is breathing in. Expiration is just the opposite. We call it exhalation or breathing out, and that's a passive process where the intercostal muscles and the diaphragm relax, causing the chest cavity to decrease in size, and that forces air from the lungs. Now, we're not so much forcing air from the lungs as that the spring is releasing and it's going back to where it should be as those intercostal muscles relax, that diaphragm relax, and the air just flows out. We're generally not really forcing it out, but we're allowing it to flow out like that. Let's talk about the characteristics of adequate breathing. The first part of adequate breathing, or the first characteristic, is the respiratory rate. And that's the number of times you breathe a minute. The rate for an adult is 12 to 20, for a child 18 to 30, or for an infant 30 to 60 times per minute. I want to caution you with vital signs. If an adult is breathing 22 times a minute and has no other symptoms, no other complaints, I'm really not going to worry too much about their breathing. However, I am going to keep an eye on it. Also, we're going to talk about the rhythm of the breathing. Is it regular or irregular? Adequate breathing is generally regular. That means that at a nice paced rhythm. You're not going to take one breath, wait for 45 seconds, and then take four more in quick succession. That's not regular. In fact, that's quite irregular. We're also going to look at chest expansion. As folks breathe in, their chest is supposed to expand, and the characteristics of adequate chest expansion are the chest expansion is adequate and it's equal, which means, and you're going to have to observe other people breathing to be able to understand what adequate means. And equal, that means are both sides of the chest expanding and contracting equally, or is one doing more than the other? If you see one side of the chest expanding and contracting and the other's kind of sitting still, you have an issue going on with your breathing. How much effort does it take to breathe? In the normal person, characteristic of adequate breathing, respiratory effort is unlabored. That means they're not having any trouble breathing. And how deep is the breathing? Is it adequately deep, or are the breaths really, really shallow? Okay, other characteristics of inadequate breathing. So let's talk about the rate again. Is it above or below the normal rate for the age group? That's if it's inadequate breathing. Rhythm, possibly irregular. Quality, that means the breathing could be diminished, could be unequal, could be absent. The chest expansion might be inadequate or unequal. The effort, such as labored breathing, and you're going to see some accessory muscle use sometimes with inadequate breathing. That might include nasal flaring. The body will open up the nose holes to allow more air to come in. You make the hole bigger. The concept is you should be able to move more air. Seesaw breathing, that's where the chest will expand and the stomach will go down. And then when the chest relaxes, the stomach comes back up. That's seesaw breathing. And the depth, when we talk about inadequate breathing, the depth of the respiration may be too shallow. Now, you don't have to have all of these things in order to have inadequate breathing, because your body is pretty miraculous. The body tries to keep everything equal, and it will compensate for one problem or another by adjusting another function. For example, if the breathing is irregular, the body may pick the respiratory rate up. Just like if your blood pressure is too low, the body will try to increase the heart rate to make up for the low blood pressure. So your body's always trying to compensate and meet this state called homeostasis. Okay, other signs of inadequate breathing or definitions of inadequate breathing. Inadequate breathing is breathing that will not support life. The patient will eventually die. So that makes it very important for us, of course. We've got to identify inadequate breathing, and we have to treat inadequate breathing, and we need to do it rather quickly, because inadequate breathing results in hypoxia. Now, that's one of those medical terminology words. Hypo meaning low, and oxia meaning oxygen. So hypoxia is low oxygen. Inadequate breathing starts to affect the body in different ways. The first organ affected is usually the brain. Early signs of inadequate breathing may include nervousness, anxiety, or an inability to be still. And later signs of inadequate breathing, as far as the brain is concerned, those may result in confusion, combativeness, lethargy, or sleepiness. You might see some skin changes, like diaphoresis, which means sweatiness. The skin may be gray or pale from inadequate circulation, or the skin may be cyanotic. Cyanotic means being in a state of cyanosis, which basically means blue color. You'll first see this around the eyes, the nail beds, and the lips, and then it'll work its way towards the center of the body. So the outside surfaces will be turning blue first. If you have central cyanosis, which means you've got neck, chest blueness or cyanosis, that's a really bad sign. That's a late sign, and it's really bad. Also, we might see some increased heart rate, because if we're not getting enough oxygen in, our heart's going to kick it into overdrive, pump a little faster to try to make most use of the oxygen that's there. So let's talk about inadequate breathing, the assessment and treatment of inadequate breathing. We always want to start with the dispatch information. If the dispatch information includes the patient has difficulty breathing, well, hey, that's a start. But what if your dispatch information says the patient has chest pain? Well, if that patient's got chest pain, we might want to be on the lookout for inadequate breathing. Also, if you have some of the more major trauma or injury conditions, we're going to look for inadequate breathing. Let's go ahead and get your initial impression. How does the patient look? Do they look like they're in distress? Does the patient look like he's having trouble breathing? Is the patient pale or gray colored? Is the patient blue? Is the patient sitting in something called the tripod position? And the tripod position is basically the patient leans forward and puts both of their hands on their knees. So the body and both arms, you've got 3 points going down, that's your tripod. You see a person in the tripod position, they're generally having some serious issues with their breathing. The last word here in this line is orthopnea, Orthopnea. Orthopnea is a medical term, which means the patient has to sit up in order to breathe. Very rarely do you see orthopnic people, but when you do, you know you've got a major emergency, especially if it's new onset. So if we're going to assess this, we're going to check airway. Well, first thing, we're going to open the airway if it's needed. If the patient's talking to you, the airway may be okay right now. We're going to reposition the patient as needed. And if you're looking at the PowerPoint, you see PRN. PRN is a medical abbreviation for as needed. We're going to provide ventilations if we need to at this point, and we're going to start making transport decisions. How are we going to transport the patient? To which facility are we going to transport the patient? And how quickly are we going to try to transport the patient? Okay, let's talk about breathing. We talked about airway, so let's talk about breathing. We're going to talk about the effort, the rate, and the rhythm, the chest expansion, the depth, the quality of the breath sounds. Now, we're going to apply oxygen as soon as you identify that need. If you do not need to ventilate the patient, maybe they're not that bad yet, let's start applying oxygen as soon as we think we need to in order to maximize the amount of oxygen breathed in. And when you maximize the amount of oxygen brought in, you will maximize the amount of oxygen in the blood. Again, we're going to start making your transport decisions at this time. Some additional breathing assessments or findings. Let's talk about tachypnea. Tachypnea is a medical term, tachy meaning fast. So tachypnea is breathing faster. And a lot of times you see them breathing faster as the problem gets worse. It's kind of like that old snowball rolling downhill. Maybe the respirations, you find them to be slow and or irregular. That's a later sign. When the body gets tired and fatigued, it starts to slow down. It can no longer compensate. The tachypnea is a compensation mechanism, but when you get so tired, then we get into that slower, irregular breathing. An inability to speak. If a patient cannot speak because their breathing is so bad, is so distressed, that's a sign of a very severe respiratory condition. You need to be on the road with oxygen, and you need to be getting there rather quickly if you can. There's other things you can be doing, and I want to make sure that, to be clear, that diesel fuel treatment is not always what's indicated. Be very, very clear of that. Be cognizant of that. A lot of times, simply being calm and treating the patient with the tools you have is just as effective for the situation as trying to drive too quickly. How about a silent chest? That's when you have no breath sounds or really diminished breath sounds. Now, when we get to the breaks on Thursday, we're going to practice listening to breath sounds. If there's no breath sounds or they're really diminished, that's a really bad sign. That's especially bad in children. We're also going to talk about the term agonal respirations. Those are dying respirations. You have those occasional breaths or gasps. They may be extremely irregular. And sometimes you hear what's called a death rattle. You will hear the mucus and secretions in the throat will make a rattling noise when the patient does breathe in and out. Things to assess with a circulatory treatment. Increased heart rate secondary to difficulty breathing is an early sign, and decreased heart rate secondary to difficulty breathing is a late sign. We're going to go through our complete assessment, OPQRST. Onset, provocation, quality, radiation, severity of time. When did it start? Describe what it feels like. And that's your cue. P is make sure or find out if anything provoked the episode. Radiation doesn't have a whole lot to do with difficulty breathing, but severity and time. How bad is the difficulty breathing, and does it come and go? Is it constant? OPQRST becomes the S in sample, and that is your signs and symptoms. Assess for allergies. Assess for medications. Assess for past medical history, last oral intake, and events leading up to the illness or injury. So if we break down sample a little bit more, A for allergies, has the patient been exposed to an allergen? That may be a cause of their difficulty breathing. Does the patient take any meds that cause difficulty breathing? Has the patient started any new medication? Years ago, we went out and responding to difficulty breathing patient. It was in another rescue squad service area. When we got there, the patient was deceased. Well, he had just started a new medication that morning. So it is potential that he had an allergic reaction. Also, does the patient take respiratory related medications? Lasix, which is a fluid pill, often taken for heart troubles, for congestive heart failure. The Lasix helps congestive heart failure by removing excess fluid and making it easier to breathe. Does the patient take albuterol inhalers? Do they take something called theophylline? Those are how medications can play into your assessment. Medications help you determine P, but you need to ask about P and P being past medical history. If the patient is a long-term COPD or black lung patient, some of the respiratory distress may be normal. These folks can sometimes be normally short of breath even at rest. Generally, folks don't call you to respond. They don't call for an ambulance if it's normal problems. They will call you when the problem gets worse. So don't discount what they're saying or discount their complaints simply because they have a history of respiratory problems. Last oral intake. You can pass that information along to the hospital because sometimes patients get worse and you're the last person that can gather that information. But last oral intake can also play into the A with sample, allergies. If someone is allergic to shellfish and they ate at a seafood restaurant before all this started, you may have some sort of cause behind the complaint. E, events leading up to the injury or illness. Well, I was eating at Long John's when I got sick. I was eating at Red Lobster when I got sick. I was running a marathon when I got sick. All those play into your assessment findings. Take your vital signs. I know we mentioned about respiratory and pulse rate. Now's the time to get a really good respiratory rate and a really accurate pulse rate. A lot of times, I think I've said this before in our vital signs section, if you're going to count respirations, don't tell the patient what you're doing because some of them will hold their breath and turn blue just to spite you. Go ahead, count the pulse, and don't move your fingers off the wrist. Leave them right there and count the respirations. The patient never knew that you were counting the respirations, and you'll get a more accurate number. Also, if you're concerned about respirations being uneven or too fast or too slow, count for a full minute. Don't just count for 15 seconds and multiply by 4 or 30 seconds and multiply by 2. Count for the whole minute so that you get a better picture of what's going on. Now we're going to talk about pulse oximetry. And if you remember back in the pulse oximetry section, the pulse ox basically sees red and it's not always accurate. Poor circulation will cause the pulse ox to read low, whereas things like carbon monoxide poisoning will cause the pulse ox to read really high. Your pulse oximeter is an assessment tool, but it's just a machine. Remember, treat that patient. Don't treat the machine. And as an EMT, I hope you're smarter than the machine. Sometimes the pulse ox may say everything is all right when it really isn't. Okay, here we go. We're going to apply O2 if it's not already been done. Somebody's having severe difficulty breathing, we're going to go ahead with 12 to 15 liters per minute being non-rebreather mask. If we need to, we're going to ventilate the patient with a bag valve mask. Generally, if they're conscious and able to communicate, they're not going to allow you to use the BVM. They're not going to allow you to breathe for them. However, you should be able to get some oxygen on those patients. Guys, we need to be transporting. If we aren't already transporting, we should be getting on the road now. Call for ALS, advanced life support, if you need it and if it's available. All systems don't have ALS backup. All systems don't have ALS available every day. Make sure that you're a competent EMT. You use the tools that are available to you to treat your patients. If you can administer albuterol out of your medication box on your ambulance, you need to be doing that instead of waiting for an advanced life support provider to come do it. We're going to reassess our patient every 5 minutes. Respiratory conditions are serious or can be very serious. They can also change in the blink of an eye. So you're going to reassess that patient every 5 minutes, and you better document it. We're going to contact the receiving facility early. Don't wait till you're starting up the hill to the hospital and say, and we're pulling in your door now, when instead you could be giving them a 10-minute ETA or estimated time of arrival. If they know you're 10 minutes out, they're going to be better prepared than they are if you just run in through the front door. Assessment of dyspnea and treatment. Again, dispatch information, BSI, body substance isolation, and is the scene safe? It's worthy to note if you've got a dyspnea patient, and especially if it's tied in with something like a fever or a cough or a history of COVID in the residence, we might want to be looking at some sort of respiratory isolation, such as a mask. A surgical mask is okay, but if you're unsure if there's some sort of organism like COVID or, well, COVID's a virus, it's really not an organism, or tuberculosis, we want to be wearing our N95 mask or our N95 respirator. Is the scene safe? Do you notice anything at the scene that might cause it to be unsafe? For example, you go into a rough neighborhood and somebody's complaining of difficulty breathing, you enter and there's all types of chemicals all over the room. That scene may not be safe. Or, as I did years and years ago with a carbon monoxide, did we walk in to the carbon monoxide environment? Yes, we did. Luckily, we got out of it quickly enough. We're doing our initial impression. How does the patient look? Are they in the tripod position or do they have orthopnea? And we're doing the airway, opening the airway. We're going to reposition as needed. Okay, we're going to talk about again, dyspnea assessment and treatment. We're going to talk about our primary and secondary assessment of patients because inadequate breathing and dyspnea are basically the same. So we've done our primary, secondary assessment. Now let's talk about a focused assessment or examination. We're going to look for or continue to observe for AMS, which is altered mental status, restlessness, anxiety, altered level of consciousness. We're going to look for unusual anatomy. Is anybody familiar with a barrel-chested patient or barrel-chested person? That's a good sign that you've got a long-term respiratory problem such as COPD, that being emphysema, black lung. Those are the ones that really result in some barrel-chested people. Barrel chest is simply, it occurs when the muscles of the chest get exercised a whole lot in the process of breathing. We're also, again, looking at position, tripod position, or orthopnea. We're going to look at the effort or work of breathing. Does the person have retractions? And you see retractions, especially with little skinny kids. They'll breathe in, and the intercostal muscles that's in the skin between their ribs will kind of suck in. You might see accessory muscle use, like using the abdominal muscles to help pull more air in, or flared nostrils. Dysphagia. Dysphagia is a fancy medical term for difficulty speaking. Talk about skin condition. This is what we're looking for. Are they pale, flushed, or cyanotic? You can observe and continue to observe for things like pedal edema. Pedal edema means swelling or fluid in the feet and legs. Sacral edema, that is swelling or fluid in the lower back of bed and chair bound patients, basically right at the bottom of their back or the top of their butt. You'll see some fluid gathering. We're going to be looking at cardiac related signs and symptoms. Tachycardia means heart's beating too fast. Bradycardia means the heart's beating too slow. Does the patient have hypotension, which is low blood pressure, or hypertension, which is high blood pressure? And if you notice on the slide, HTN, capital H, capital T, capital N, is an abbreviation for hypertension. Does the patient have chest pain? Do they suffer from chest pain when they breathe in? Do they suffer from chest pain only when they breathe out? Or is it a constant pain? We're going to continue to watch the pulse ox and see if the pulse oximetry readings change with treatments or time. Treatment like oxygen administration should increase the pulse oximetry reading. If you are providing albuterol, it should result in an increase in your pulse ox reading. We're going to check for breath sounds, and we're going to look at these breath sounds over here on our next slide. Breath sounds. We're going to use your stethoscope for this. This is probably just as important of a use for your stethoscope as blood pressure. It may be more important, a more important use of your stethoscope than just taking blood pressures. We're going to listen front and back. We're going to listen in all fields, at least upper and lower, front and back. Now, if you remember, you've got 3 lobes on the right side, 2 lobes. The left lung has 2 lobes, right lung has 3 lobes. You can listen in 3 spots on the right, 2 on the left if you want to, but go and listen to the back. Try to listen in a quiet environment if you can. Tell everyone to be quiet. I've got to listen to breath sounds. Tell your patient to stop talking while you're listening to their breath sounds. And just like that, I hope they don't cough while you're listening, because sometimes that can be a deafening experience. Reassess your vital signs, or reassessment with vital signs and after medication. I believe it should say reassess often, at least every 5 minutes, and after medication, being sure to take vital signs. That might be a better way to put that in there. Talk about different types of breath sounds. Let's talk about wheezes. Wheezes are high-pitched, almost musical in nature sounds that you're going to hear when you auscultate. That's the medical term for listening. So when you auscultate breath sounds, if you hear high-pitched musical sounds, most common during exhalation, that's most likely a wheeze. It indicates a narrow air passage. Some associated diseases and conditions with wheezes include asthma and allergic reactions, chronic bronchitis, chronic obstructive lung disease such as COPD or emphysema. We've also got the term rales. I'm a bigger fan of crackles. All that is fine, bubbling or crackling sound, usually in the base of the lungs, usually on inspiration or breathing in. It indicates fluid in the airways. Some associated conditions that result in crackles or rales are pulmonary edema, congestive heart failure, especially left side CHF, and renal failure. Go back, talking about renal failure. Think about how renal failure could be associated with difficulty breathing. The kidneys and the lungs are two separate systems, but your body constantly works together. All the systems work together. So be thinking about that, and I'll ask you about that on Thursday. Bronchi. Bronchi are another breath sound that you might pick up. They're generally lower pitched. They resemble rattles or snoring. They're very similar to crackles, but they're louder. They indicate larger airways contain secretions. That's probably why you hear them better. Some associated conditions with bronchi are pneumonia or bronchitis or aspiration. Aspiration means to inhale some sort of substance into the lungs. Maybe it's vomit, maybe it's blood, maybe it's oil. Who knows what the substance is, but when you aspirate, you suck it in, and that can result in conditions such as pneumonia. In fact, we lose a lot of elderly people to aspiration pneumonia every year. Stridor is much higher pitched. It's inspiratory. That means you hear stridor when the patient breathes in. It indicates a partial obstruction, possibly of the trachea or larynx. And stridor is usually heard without a stethoscope. You'll hear them when you walk in the door. If you hear stridor, that is an emergency. Kind of should increase your classification of your patient. You should really see this person as having a more severe emergency than the person who doesn't have stridor. Pediatric considerations. Some respiratory conditions are chronic in children. How many folks either have or have had children that had bronchitis all the time, like chronic bronchitis or asthma? Another pediatric consideration, airway structures are usually smaller and more easily obstructed. Makes sense. Children compensate very well, and then they crash quickly. So if a child has a respiratory ailment or any ailment, the body is going to kick it into overdrive. They're going to compensate for that problem really well, and then all of a sudden they just give up and quit. They stop compensating, they crash on you. Respiratory conditions are the number one cause of cardiac arrest in children. It's not heart problems. So let's manage dyspnea. Dyspnea is the medical term for difficulty breathing. First part of our assessment. The assessment is the foundation of patient care. If you don't assess your patient, if you don't do a good job assessing the patient, your care of the patient is probably going to suffer. We want to assess them well, but we also want to assess early on and we want to assess them often. Kind of like going to the polls. We're going to go early and we're going to go often. Oxygen. We're going to start administering oxygen as soon as you determine they need it and as soon as oxygen is available. So if you brought oxygen into the scene with you, you can administer it more quickly. Some agencies have oxygen tanks in a bag that they carry in. Some agencies have oxygen tanks secured to stretchers. It just depends on what your agency does. But as quickly as you determine the oxygen is needed, put it on them if it's available. If it's not available, send for it really quickly. Send your partner to go get the oxygen. You can give the patient 15 liters per minute of oxygen via non-rebreather mask. And guys, if they're in a really severe respiratory condition, if they have that, go ahead and try. Also, if the patient will not tolerate a mask, let's try a nasal cannula at 6 liters a minute. We want to aim for an SpO2 or oxygen saturation of 95%. Now, some texts say if you have a COPD patient, such as somebody with emphysema because they've smoked a whole lot, or an old coal miner who's got black lung, 91% is adequate for that patient. Again, you've got to be able to assess your patient and determine what they need. Treat your patient, don't treat the machine. Other ways we manage dyspnea. How are we going to position our patient? We're going to position them in Fowler's or semi-Fowler's position. That is sitting up on the stretcher. Of course, their feet are generally going to be out in front of them because they're on the stretcher, but you're going to elevate that head and back if you can possibly do it. If the patient has a prescribed inhaler, and your protocol allows you to administer either by calling medical control first, or if you've got a written standing order to go ahead and give that. We're going to make sure that we have the patient's medication if it's a prescribed inhaler. We're going to look at the expiration date and we're going to obtain medical control approval if you need to do that. Some systems and some agencies are now getting into something called continuous positive airway pressure, CPAP. It keeps the airways open by constantly forcing some air in. Now, it requires special training and protocols. If your agency does CPAP, then you have got to receive additional training in order to do that. You owe it to your patients to learn. Okay? We're going back up prescribed inhalers for just a minute. Some patients have prescribed inhalers. They usually contain albuterol, which is a bronchodilator. Bronchodilators open up the airway. They treat bronchoconstriction, which is a constriction or a blockage of the bronchi that lead from the trachea to the lungs. How do they do it? They relax the smooth muscle that surrounds those airways and they open up the airway. A side effect of a bronchodilator inhaler, it may cause nervousness, it may cause dizziness, it may cause elevated heart rate. In and of themselves, each of those situations are not a major problem unless the heart rate gets really high. And I'm going to say over 100 to 110, then I might question if that prescribed inhaler done that. But if I give a patient their inhaler and they get a little nervous on the cot, so be it. Remember your 5 rights with prescribed inhalers: right medication, right time, right route, right patient, right dose. Is it indicated? When we talk about right time, has it already been used and when? Yeah, if you read the instructions on the medication, it said they can take it every 4 to 6 hours. It's now 3 p.m. in the afternoon. They haven't taken it since 9 a.m. Okay, so we're in the right time range. Right route, inhalers are breathed in or inhaled. I mean, that's not a PR medication? Is it the right dose? Prescribed inhaler that belongs to a patient, you must make sure it belongs to that patient, not their cousin or neighbor. And the right dose, that's generally per medical control, whether medical control is live or medical control is via standing order. When we're administering inhalers, of course, we're going to assess your patient first. And I know this is like beating a dead horse, but you need to assess your patient regardless. In all situations, you assess your patient. We assess for OPQRST, we assess for sample, we assess vitals, and we assess breath sounds. If you're giving the patient an albuterol inhaler, they should already be receiving O2. You should already be thinking about transport. Get permission from medical control, again, live or by standing order. Now, we're going to administer to the patient. A lot of times patients already know how, but we can coach them a little bit. I always like to go through it and say, this is what we're going to do. This is how we're going to do it, and then actually follow through with the administration. So first, we're going to shake up the device because most of these devices are really a powder with a gas to push the powder out of the inhaler. So you need to shake it up and break that powder loose. Break up the clumps. Take a deep breath in and blow it out. As you start breathing in, activate the inhaler and continue to breathe in. Hold your breath. Blow it out and repeat if directed by medical control. So I'm going to have the patient shake it up, take a deep breath in and blow it out. Sometimes that causes them to cough, and that's okay. As the patient starts to breathe in, we're going to squirt or activate the inhaler while they continue to breathe in. The reason is you want them to breathe in all of that medication. Have the patient hold their breath. That gives a few moments for the medication to be absorbed into the lung tissue, and then you have them blow out. Have them blow out so they can get another breath. Repeat it again if directed. So we're going to coach the patient through the medication administration and use. We're going to repeat it if ordered. We're going to reassess every 5 minutes. Every 5 minutes. If you're not going to reassess every 5 minutes, you're doing your patient a disservice. If your patient is sick enough to need medication in the field, if they're sick enough to get that medication from you as an EMT, they're sick enough to be reassessed. We're going to transport that patient if we're not already transporting. We're going to update medical control or the receiving facility as to what happened. Has the medication helped the patient? Has the medication made them worse, or has it not changed at all? And when you get your PowerPoint presentation emailed to you, there's some YouTube video links that I think help explain that real well. Okay. That is as far as our little video or slideshow goes, where we talk about medications and difficulty breathing, as to how we assess that difficulty breathing and where we go from there. Close that out on my computer, so hopefully it will reduce the lag. I'm trying to bring it back to full screen. Okay. What we need to remember, what we need to talk about and think about is assessment, assessment, assessment. If you don't assess your patient, you're going to have problems. your patient is going to have problems. And I hope I haven't lost everyone here. Says we are still recording, but for some reason I've lost my camera. Anyway, I will see everyone at the breaks this Thursday, and I believe that will be March the 14th at noon. We'll continue this discussion. We will practice our patient assessment, and we're going to practice administering those albuterol inhalers. I am going to go ahead and bring an nebulizer treatment set so you can see how that works. And depending on your protocol, depending on your agency, you may be able to pull that medication off of the drug box, place it in the nebulizer, and administer it. I want to thank everybody that watched this video. I again want to apologize if you missed it or if it's a little rough to watch. The link will be posted this afternoon or this evening late, along with the PowerPoint for you to watch. All right. Thank you.